This is a brief introduction for those of you in internal medicine rotating through the hematology ward and consult rotations on practical transfusion medicine and things you might need to learn from the blood bank perspective. This is meant to be a brief introduction to the topic and is not meant to be exclusive. This is Dr. Wong from the University of Alberta Hospital Hematopathology Division. So today we'll focus on the first 4 topics listed: general blood product utilization, the difference between a type N screen versus a cross-match for transfusion medicine testing, a general approach to transfusion adverse events and reactions, and specifically the use of prothrombin complex concentrates, which go under the brand names of Octaplex and Beriplex. At some point in your rotation and clinical experience, someone will be going through the reversal and bypass of the new oral anticoagulants with you. And we will not be covering the Edmonton Zone Massive Hemorrhage Protocol today, but you will probably encounter that later on in your clinical rotations at some point. So generally what's available in the blood bank, you're probably most used to using the cellular components, meaning the components derived from a whole blood donation. So the red cells, platelets, plasma, and cryoprecipitate. So for example, if you go to donate CBS, to donate whole blood at CBS today, then your whole blood is collected and then will be sent to the second floor to be centrifuged and separated out into the red cells, platelets, plasma, and cryoprecipitate. The red cells are drained out at the bottom via gravity, whereas the plasma is squeezed out via the top of the bag, again in another device. What's remaining in the original donation bag is your buffy coat white cells and your platelets. And plasma is then processed by freezing it at -18 Celsius or lower and then stored completely frozen. Cryoprecipitate is generated by putting plasma into the refrigerator so that the protein fraction of interest precipitates out, and hence that's why it's called cryoprecipitate. The blood bank also has additional fractionated products, coagulation factors, for example, recombinant factor 8 for the treatment of hemophilia A, recombinant factor 9 for the treatment of hemophilia B, for example, and these are recombinant products. The only other product on this list that is recombinant is recombinant factor 7A. None of the other products are recombinant, and they are derived from vats and multiple units of human pooled plasma. Going on, FIBA stands for factor 8 inhibitor bypass agent and is also known kind of as activated PCC. FIBA is used for the treatment of acquired factor 8 or 9 deficiency for which the patient has already developed an allo antibody against the factor 8 or 9 as a pathologic process. The other product used in that indication is recombinant 7A, and those are the only 2 major indications or licensed uses for FIBA and recombinant 7A. Recombinant 7A is also licensed for the treatment of congenital or hereditary factor 7 deficiency. Hume-AP is the product used to treat von Willebrand's disease, and Hume-AP also has some factor 8 in it in the product. Prothrombin complex concentrates are used for acute emergency reversal of Coumadin or warfarin anticoagulation or vitamin K deficiency in the setting of life-threatening bleeding or emergency surgical procedure required within 6 hours of the infusion, and we will go through that a little bit more detail later. IVIG, we'll go through that a little bit later as well. And there are also other immunoglobulins in the blood bank. You're probably most familiar with Rh immune globulin, used to prevent hemolytic disease of the neonate or fetus in an Rh blood group negative woman who may be having an Rh positive blood group fetus. Other immunoglobulins as listed, for example, will be hepatitis B immunoglobulin and CMV immunoglobulin, and there are more. This list is not inclusive. Albumin, antithrombin, and C1 esterase inhibitor are also available in the blood bank, and we will not be going through their specific uses today. In terms of the component blood products, here are the shelf life, storage, and volume of each product. Red cells and red cells are stored in the refrigerated temperature between 1 to 6 degrees Celsius and has a shelf life of 42 days. Each red cell unit is about 280 cc's. A good number to remember from this table is 300 cc's because that's about the average volume of each red cell as well as each platelet. Now, pooled platelet comes from a whole blood donation from 4 different people's platelets pooled into one bag to make the pooled platelet. An apheresis platelet is a single donor platelet donation. Regardless of whether you're dealing with a pooled platelet unit or apheresis platelet unit, platelets are stored at room temperature with constant mixing to allow gas exchange between the platelets and the environment, and has only a shelf life of 5 days. And the pooled platelet volume is about 350 cc's per bag, whereas the apheresis platelet bag has about 300 cc's of volume in it. These volumes will become important if you have to calculate the ins and outs of a patient, for example. Plasma, whether frozen or single donor apheresis plasma, are stored completely frozen at minus 18 Celsius or lower, and the shelf life at that storage temperature is 12 months. Frozen plasma, each bag is around 250 cc's. Apheresis plasma has an average volume of about 500 cc's per unit. Cryoprecipitate, again, is stored completely frozen at minus 18 Celsius or lower with a shelf life of 12 months, and each unit is only about 15 cc's. By definition, plasma has all your coagulation factors and anticoagulation factors in it, so by definition, plasma also has what cryoprecipitate has, which is primarily the source of fibrinogen. Each unit of plasma would have about the same fibrinogen content as about 2 units of cryoprecipitate, but of course the volume you're dealing with is much different. So general notes on blood product utilization. If the patient is not actively bleeding or hemolyzing or otherwise consuming red cells for some reason, and you're just dealing with a bone marrow failure or production problem, each red cell unit should raise your baseline hemoglobin level by about 10 grams per liter. The adult dose for platelets, whether you're dealing with an apheresis unit or pooled platelet unit, it is 1 bag of platelets. In general, because platelets are always in short supply regardless of blood group, the blood bank will never issue 2 platelets units at once on any one patient. The guideline is to issue 1 unit of platelets and then clinically monitor whether there's a response, or by doing a 1-hour post-transfusion platelet count to see if there's an adequate increment in your platelet number, and then decide whether additional units or other interventions are needed. The normal platelet range in the CBC is anywhere from 140 to 450, depending on the lab and the local reference range, but there is a lot of reserve in terms of your platelet number under normal physiologic conditions. So you would probably realize that there is no need to give platelets transfusions prophylactically to prevent spontaneous bleeding unless the platelet count is less than 10 times 10 to the 9th power per liter. There are general guidelines regarding different platelet thresholds. If you are having to send the patient onto a surgical or interventional procedure with a high risk of bleeding, we would like to keep the platelet baseline above 50. If you're trying to send the patient for a neurosurgical procedure, retinal surgery, spinal cord procedure, etc., then ideally we would like the platelet threshold above 100, but that is not always possible to do given inventory issues. 1 unit of platelet should raise your platelet count by 15 to 25 times 10 to the 9th power per liter, measured at a 1-hour post-transfusion platelet count. You probably have heard of the term platelet refractoriness. That term is referring to immune cause for not having the adequate platelet increment after the transfusion, and that's because platelets, like a lot of other cells in the body, have HLA antigens on them and human platelet antigens on them for platelets. And unless you have an identical twin in which your HLA makeup and HPA makeup are exactly the same, otherwise you're always having exposure to different people's HLA antigens and HPA antigens. So if you are alloimmunized due to multiple transfusion episodes to some other person's HLA antigens or HPA antigens, then you may actually clear the platelet transfusion very rapidly after it is infused, and hence true platelet refractoriness refers to HLA or HPA alloimmunization. There are many other reasons to consume platelets. If there's underlying fever, septic process, infectious process, systemic inflammatory response, DIC, for example, hypersplenism, splenomegaly, those are all other reasons to exclude before considering a platelet refractoriness investigation at the HLA lab. Remember, plasma and cryoprecipitate need time, about 15 minutes, for the blood bank to thaw back into the liquid state before the units can be issued out to the patient. So keep that in mind when you're asking for plasma and cryo. In terms for cryoprecipitate dosing, cryo is used as a source to replace fibrinogen. And in general, you're only eligible to receive cryoprecipitate if your fibrinogen is less than 1.0 grams per liter. So if you're requesting cryoprecipitate, please ensure that you have already asked for the PT-INR, PDT, as well as a fibrinogen level to determine whether you actually need cryoprecipitate to begin with. The dose for cryoprecipitate is 1 unit for every 10 kilograms of body weight. So in general, a 70 kilogram person will require about 7 units of cryoprecipitate, but since we are only issuing cryoprecipitate when someone is actively consuming fibrinogen, most commonly because of a disseminated intravascular coagulopathy or DIC, the dose is actually rounded up to about 10 to 14 units of cryo for a 70 kilogram person. Each unit of cryoprecipitate should raise the fibrinogen by about 0.5 grams per liter. And remember, I was saying before, plasma has all your coagulation factors and anticoagulation factors. So by definition, plasma also has fibrinogen. But plasma should be used if you're dealing with a global coagulation factor deficiency, such as, for example, DIC. And 1 unit of plasma will have the same fibrinogen content as 2 units of cryoprecipitate, but of course, you are dealing with 250 cc's of volume in 1 unit of plasma, whereas 2 units of cryo will only be about 30 cc's. Moving on to IVIG, there are 2 main dosing regimens. The dosing regimen for IVIG for immunosuppression, for example, your classic ITP patient, will be 1 to 2 grams per kilogram total dose. For immune replacement, whether primary immunodeficiency or secondary immunodeficiency due to an underlying lymphoproliferative disorder with frequent infections and a low baseline IgG level, for example, that dosing regimen is 0.4 to 0.6 grams per kilogram every 3 to 4 weeks. Regardless of the underlying indication for IVIG, the maximum total dose is 2 grams per kilogram at any one point in time. So if your patient weighs, let's say, 150 kilograms and he or she comes in with a diagnosis of ITP and you're requesting 1 gram per kilogram of IVIG to start, then the blood bank will cap that single dose at 100 grams on that day. And then the idea is to monitor in 24 hours to see if there's a response in terms of clinical symptoms and in terms of the platelet count with an adequate rise before you decide whether the 2nd gram per kilogram is required. The reason why we cap the maximum total dose for any indication of IVIG at 2 grams per kilogram is because there are certain risks involved with the product. Hemolysis usually occurs 7 to 10 days after IVIG infusion, so every patient who receives IVIG as an outpatient also receives a requisition to have their CBC and reticulocyte count checked in 7 to 10 days to monitor for that. And thromboembolic events, aseptic meningitis, renal failure, and anaphylaxis are also risks associated with the IVIG product. And there are published IVIG utilization and dosing guidelines available in each province, and they're actually very similar. So if you're requesting IVIG for a clinical indication that is not on the guidelines, or your dosing frequency or the dose that you're requesting is not as per recommended in the guidelines, then expect a phone call from our IVIG utilization manager just to have a discussion around the case.